participant, Jayaram, is going to talk about high stakes, high standard surgical precision for EDOF and multifocal. Over to you, Jayaram.
Thank you, Navarush and KSOS for having me here. So I'll be talking here regarding surgical precision for EDOF and multifocal IOLs. As you can see here in the global IOL usage trend, the EDOF and multifocal IOLs are on the rise. So every cataract surgeon should be very well versed with the surgical nuances of implanting a multifocal or EDOF IOLs. So regarding the pre-op reference marking in toric IOLs, either you can use a image guided system or marking you can do on in the OR with patient upright to avoid cyclotorsion errors. And topical anesthesia is preferred for better fixation and less pressure and quicker recovery. If the patient is anxious or has tremor or poor cooperation, you can use peribulbar. And always communicate with the patient regarding the bright light, and you have to look into the light and be cooperative, and you can talk, then it will be very helpful. Then regarding the incision, clear corneal temporal incision is standard. A steep axis incision of 0.5, 0.75 without toric component will be good. And square self-sealing incision, target wound size around 2.2 to 2.4 to minimize astigmatism. And symmetric parasynthesis to reduce vector surprises. For multifocal IOLs, proper axis marking is absolutely critical. The single most important step is a perfect capsular axis. Target the size to 4.5 to 5 and 360 degree overlap always will help to reduce the tilt and decentration and minimize postoperative PCO and capsular phimosis, and it also improves the predictability. So while doing this rexus, it is very important to center it perfectly, perfect centration of the visual axis. You can use the Purkinje reflex rather than solely on the pupillary center. And practical method is to ask the patient to fixate and note the coaxial light reflex and center the axis around the point. And use trypan blue staining in white cataract or poor red reflex. Femtocapsulotomy, if it's available, it will be more precise. In small pupils, always use pupil expansion devices and never compromise on rexus centration size to avoid using a ring. So phacoemulsification, you can use all your normal technique, but to avoid pushing the nucleus excessive manipulation that stresses the zonules. Cortical cleanup should be thorough, and you should do a proper good posterior capsule polishing to avoid early PCO, which is critical in multifocal IOLs due to contrast sensitivity issues. Then in toric IOLs, you should align the IOL exactly on the axis, because 1 degree misalignment will cause around 3.3 loss of toric effect, 10 degree will cause almost 1/3 loss, and 30 degree will cause almost total nullification of the toric effect. So you put the lens and then do the viscoelastic cleaning by keeping around 10 to 20 degree short of the final axis, and then rotate it to the final axis using irrigation. So this is case in which you use the toric marker to align the lens to the final axis. In manual marking, you can always mark the axis and then rotate to that particular axis to get the best result. So IOL insertion, you choose the right cartridge and incision size to avoid wound stretch and induce astigmatism, and should properly place it in the capsular bag. Haptic position, confirm both haptics are within the bag and fully open. And after achieving perfect centration, after full unfolding cortex removal, check centration against Purkinje reflex and the limbus. If slight decentration is noted, rotate, slightly nudge the haptics to recenter the IOL for optimal visual alignment. So the OVD should be nicely removed. It can cause, if retained viscoelastic, can cause, if it is behind the IOL, it will cause unnecessary refractive surprises also. And when to avoid multifocals. If there is a posterior capsular rupture which is large, then you should avoid it. If there is extensive zonal dialysis or inadequate rexus support, preferred alternative is to use a monofocal IOL in the sulcus. Multifocal IOL is generally contraindicated in the sulcus due to tilt, pigment dispersion, and dysphotopsia. Femtosecond laser, if there is, you have it, it is gives highly reproducible rexus size and precise, accurate incisions for astigmatism control and enhance surgical precision. So wound closure, you hydrate the wound gently to avoid corneal edema and induce astigmatism. Check for the integrity of the wound and especially check the toric multifocal to be kept in the exact axis. So final intraoperative checklist will be the IOL centration. You should check with the Purkinje reflex. Chamber should be adequately tight, toric axis alignment, and anatomical integrity. So these are two cases. One is manual, another is with femto. As you can see here, the rexus centered on the Purkinje image. You can phaco. The anterior capsule also should be washed nicely to remove the residual lens capsule cells. OVD should be removed from behind the cell, behind the lens also. Wound is hydrated. So both flax and conventional phaco with MF IOL will give good results, but as you can see here, it will the flax will give more consistency in IOL centration and effect of tilt and aberrations. This is one case which is post-op, which had a decentration and dilated. Here you can see the asymmetry between the rexus margin and the IOL edge. And patient had 6-9 vision, but he had visual phenomena. So we did a rotation and realignment. As the patient was taken up after 1 month, so there was some adhesions. So we released the adhesions and rotated the IOL. And it is nicely centered. Post-operatively, his IOL was well centered and had 6/6 vision without any other issues. So the take-home points are good preoperative mark and well-centered 5 mm axis, meticulous attention to IOL insertion, centration, OVD management, and wound closure ensures optical outcomes. Technology enhances but never replaces surgical precision and clinical judgment. Thank you.
Thank you, Jayaram, for a precise view about the not only implanting the premium IOLs, but there are a lot of other matter, especially when you're implanting a premium IOL, you should be very much aware of that visco removal and all other visco removal, and also aligning the exactly the any of the toric IOLs in the exact axis is also much more